Okay, everyone. Just now it's time. It's time for us to start the webinar. Okay, ladies and gentlemen, good morning, good afternoon, and some friends in different countries, good evening. Hope everything goes fine in your side and everyone is safe from COVID. I'm Bob from RAINMED Medical Inc. I'm honored to be here to welcome you to attend the RAINMED Medical Inc. webinar. Today we have three parts in the schedule, and the first part, advanced technology developed by RAINMED, will be presented by Professor Hall. The second part is a product short video show. Of course, during this part, we can have a short break at the same time. And the last part is some experience sharing from Malaysian expert Dr. Alan, who has devoted himself to the FFR scientific research with the flash angio CFFR system. Okay, for the meeting display, we would close your microphone during the presentation. Please kindly keep the screen share service closed, or others couldn't see the screen. If you have some thoughts or questions, you can drop them in the schedule. We will arrange to answer at once or twice. We would send the questionnaire for this webinar, and we hope you can give us some feedback to help us improve the online performance. Okay, before we start the first part, please allow me to introduce the guests for today's webinar. Professor Yunlong Huo and our special guest expert, Dr. Alan Feng. Professor Huo was one of the scholars in Young Overseas High-Level Talents Introduction Plan program in 2012. He is now a distinguished professor at Shanghai Jiao Tong University, working on coronary hemodynamics research. Welcome, Professor Huo. And next is Dr. Alan Feng. Dr. Feng is a consultant cardiologist of Sarawak Heart Center, who will be the host of the third part's presentation. He is a member of the Executive Council and Scientific Advisory Board of Asian Pacific Society of Cardiology, and he's also the current Vice President of the National Heart Association of Malaysia. Welcome, Dr. Alan Feng. Okay. Next part, let's start the first part. Welcome Professor Huo to share the technologies and the concepts of CFFR and CIMR. Welcome, Professor Huo.
Thank you. Good morning, friends. Good afternoon, friends. I think for John, it should be good night. Because Zoom is not friend to China, so my laptop, I cannot use my laptop. I have to use my cell phone. So I have to ask my colleague to pop up the PowerPoint. I will do the presentation. Can you hear me?
Yeah, we can hear it.
Yeah, that's great. Please. Please go to the first page. The third page, yeah. Hello, friends. This is Yunlong Huo from Shanghai Jiao Tong University. Today, I will introduce angiography-derived hemodynamic parameters. Next. Yeah, I think most of the doctors using the angiography to determine the stenosis, and then based on the diameter stenosis or area stenosis to decide, do we need to put the stenting or not? This calls anatomical strategy. In most of the cath lab, most doctors use it. Some very complex case, they use OCT or IVUS to improve the diagnostic accuracy. But only based on the anatomical strategy, we cannot determine the myocardial ischemia. If you want to determine the myocardial ischemia, we have to use a physiological strategy. At present, there are many parameters, but the most famous is a fractional flow reserve. Normally, we call it FFR. In 20th centuries, I think it is 21st centuries, some doctors propose another parameter called IFR, that's instantaneous wave-free ratio. Also, some very similar parameters like the diastolic pressure ratio, resting full cycle ratio, and so on. And those parameters are using the resting blood flow. That's different from the fractional flow reserve. The major objective is they don't need to use adenosine because you know adenosine is very expensive. Except for the FFR and IFR, Dr. William Faven proposed an index of the microcirculatory resistance. He called it IMR. The IMR, the major objective of the IMR is to determine the microcirculation resistance. It's measured in the arterial bed. Next page. First, let me introduce FFR. From the basic theory, the FFR, the definition of the FFR means is a patient who has no stenosis, and then after he has the stenosis, his myocardial blood flow will be reduced. So the FFR equals to the reduced myocardial flow due to stenosis divided by the flow rate at the normal case. But in most of the situation, we cannot determine the because the patient will not go to the hospital to determine the coronary blood flow. So Dr. Nico from the Netherlands, he first in 1993, he first proposed the FFR using the PD over PA in the maximal hyperemia. Why we need a maximal hyperemia? In the maximal hyperemia, the blood pressure is linearly proportional to the blood flow. So in that case, the FFR equals to, using some mathematical formula, Dr. Nico derived the FFR equals to PD minus PV divided by PA minus PV. Here the PD is the pressure, the distal pressure to the stenosis about 2 centimeters downstream. PA is aortic blood pressure. That's mean aortic blood pressure. PV is a venous pressure. In most of the case, we assume PV equals to 0. So FFR equals to PD over PA. At current situation, normally we use a pressure wire to measure the distal pressure. That means the distal pressure to the stenosis, and then using the aortic pressure sensor to determine the mean value of the aortic pressure wave, and then we can determine the FFR value. Next page. Why we need to use the FFR? Dr. Nico did a lot of clinical trials. He found that when the FFR is smaller than 0.75, that means this patient has a myocardial ischemia. That's almost 100%. We can sure this patient has the myocardial ischemia. When FFR larger than 0.8, more than 90% patients has a low possibility of the ischemia. And between the 0.75 to 0.8, in this range, the doctor will determine the patient has a ischemia or not. First, after the FFR was proposed, and Dr. William Feven, they did a FAME clinical trial. After the FAME clinical trial, most of the doctors realize the FFR can get the improvement of patient outcomes. Also, the FFR have significant resource savings. If we don't use FFR, for the stenosis for patient with a stenosis in the range of 50 to 70%, 50 to 70% stenosis, more than I think the more than 1/3, that means 35%, will omit. That means they need to treat it, but the doctor didn't treat them. But if the patient has a stenosis larger than 75%, that means very severe stenosis, more than 20% patient will be treated by the stenting. But in this case, we think we don't need to treat it, but they can only take the medicine. That's good enough. So next page. After the FFR is used to determine for the epicardial stenosis, that means FFR is smaller than 0.75 when the stenting, the epicardial stenosis. FFR is larger than 0.8. We don't need to carry out the stenting for the patient. But in half patient, almost half patient in the stable angina, we found that means the patient the patient has a normal epicardial artery diameter, but the patient still has the angina, myocardial angina. What causes it? That means they cause it by the microvascular disease. How can we determine the microvascular disease? Dr. William Feven proposed a new parameter he called IMR. IMR equals to PD times TMN in the maximal hyperemia case. The PD is distal pressure. The PD is exactly same to the FFR, but the TMN is using the thermal dilution method. We're still using the pressure wire, but we can use the thermal dilution method to determine the TMN. The TMN is inversely proportional to the flow velocity. That means we use IMR equals to PD over the flow velocity. And it characterizes myocardial blood flow in the unit myocardium. So different from the FFR, IMR has different clinical applications. For example, a patient has abnormal stress study and angina, but has no significant epicardial coronary lesions. Also a patient has successful PCI, but continues to have angina. Also a patient presenting with acute coronary syndrome. Also a patient, especially for patient after heart transplantation. So FFR and IMR, they have different clinical applications. FFR and IFR, they used for the stenting for the determination of the stenting, but the IMR used for the microcirculatory resistant evaluation. Next page. In the global, the FFR is a class 1A recommendation for guiding stenting. That means guiding revascularization. The IMR is class 2A recommendation for risk stratification, especially for the microvascular resistant evaluation. But in the whole world, the FFR and IMR, very few doctors use it. The major reason is the pressure wear is inconvenient. Also, the FFR and IMR, we need to use adenosine to induce a maximal hyperemia. For the maximal hyperemia, normally for one patient, we need 5 bottles of the adenosine. 5 bottles means one bottle almost $250 US. 5 bottle means more than $1,000 US for the doctor to induce a maximal hyperemia. It's very inconvenient. So we can go to the next page. So Dr. Charles Taylor from Stanford University, he collaborated with also another doctor from Stanford University. They create a heart flow company. In the heart flow company, they have a very famous software they call the FFRCT. The FFRCT, they use they based on the normal CTA. That means, and then coupled with the routine pressure measurements, and then they use a CFD method, that's computational fluid dynamic method. They can estimate the FFR value only based on the CTA images. But for the FFRCT, is good for the FFR is smaller than the 0.75 or larger than 0.85. In the gray zone, the accuracy is only the accuracy. That means when they compared with the pressure wear measured FFR, the accuracy is only in the 50 to 70%. That means very low. In this year, they also have the registry. They have the registry clinical trial. They have the 2-year follow-up evaluation. Also in the gray zone, and their follow-up results is still not good. That means the FFRCT can only be used for the primary clinical evaluation. We need to very accurate diagnosis of the FFR. So in 2013, Dr. Tu Shengxian first proposed angio-derived FFR. We can go to the next page. The angio-derived FFR is used in the CAS lab. Normally, we use based on the angiography and also based on the angiography and also some non-invasive measurements, we can determine the FFR value. In collaboration with Suzhou RAINMED company, we also developed a new device called the CAFFR, that's angio-derived FFR. We can go to the next page. In the angio-derived FFR, there are 2 significant improvements. First is no need for the wear manipulation. Second, no hyperemia stimulus. Also, using the angio-derived FFR, we can accurately to determine the FFR value. Most of the angio-derived Angiography-Derived FFR software and the device can get the accuracy larger than 90%. In the whole world, there are three kind of FFR products, angio-derived FFR products. The first is Medis QFR. The second one is FFR angio from the Israel Castworks. And the last one is the CAFFR from our company. We call the RAINMED company. And the first two products using the mathematical formula to estimate the pressure gradient across the stenosis. The CAFFR using the CFD method to accurately calculate the pressure gradient across the stenosis. And then we can go to the next page. In the CAFFR, I can simply to introduce. Normally, we based on the angiogram from two projections. This one is in the routine angiogram operation. That means these two projections, the doctors will do the angiogram normally. And these two projections is larger than 30 degrees. From the angiogram from the two projections, we can three-dimensional reconstruction of the coronary arteries, so we can get the length. Also, we can use the TIMI method to determine the flow velocity, in coupled with the three-dimensional coronary arterial tree. So this TIMI method, we can get the flow velocity very accurate. But in this case, we're still in the resting flow velocity. And also we have some mathematical model to estimate the resting blood flow from the resting blood flow to the maximal hyperemia. And then we coupled with aortic pressure waveform. We input the aortic pressure waveform and the flow velocity, and the 3D reconstructed coronary arteries into our console. We can generate the mesh of the coronary arteries, and then using the computational fluid dynamic model, we call the CFD method, to calculate the pressure gradient from the inlet to the most distal position. In this case, we know the aortic pressure waveform. We know the we know the pressure gradient. We can calculate the pressure value at each point along the entire coronary arteries. So we can calculate the FFR value. And then we can go to the next page. First, I have to introduce the fluid dynamics, the blood flow dynamics that we call the hemodynamics in the coronary arteries. When we have the stenosis, we have very complex flow patterns. If we divide the stenosis region called, we have the entrance lens. Also, we have the fully developed lens. Also, distal to the stenosis, we have the distal region. In this distal region, we have the flow vortex, and also we have the flow separation and the stagnation point flow. We have very complex flow situation. But how can we accurately to solve the flow velocity and also the pressure drop across the stenosis? Using a simple mathematical model is very difficult. The most accurate model is the CFD model. That means we divide the whole vessel into the mesh, and then we can calculate the flow velocity and the pressure at each point in the mesh. Here, I want to introduce my previous study. In my previous study, I did a lot of clinical studies and also the numerical simulation. I found I found the stenosis geometry can induce a pressure drop. The stenosis geometry has a 50% effects on the pressure drop. The flow velocity, that means the maximal flow velocity, have 30%, more than 30%, close to 40% effects on the on the pressure drop across the stenosis. And the aortic pressure has a 10% to 15% effects on the coronary on the pressure drop across the stenosis. That means if we want to accurately to get the FFR value, we must consider the geometry. That means the stenotic geometry. The second, we need to the accurate flow velocity. And the third, we need accurate aortic blood pressure. That means we need 3 parts. The FFR-CT only can estimate the geometry and estimate the flow velocity and estimate the aortic pressure. So for the gray zone is not accurate for the FFR-CT. But angiography, based on the angiography and the aortic pressure sensor, we can determine the aortic pressure waveform. In this case, we can get very accurate results because we satisfied these 3 conditions. We can go to the next page. In the CAFFR, we have the aortic pressure waveform. We know the geometry. We know the flow velocity, and also we can divide the whole coronary arteries into the mesh. You can look at in this mesh. We can calculate the flow velocity and the pressure in each point in the mesh. So the CFD method is at present, the CFD method is the most accurate method to solve the flow velocity and the pressure, in the coronary arteries. So we can go to the next page. And we have the CAFFR device. The next part, we need to evaluate the diagnosis performance of the CAFFR. So in 2018, we carried out the FLASH-1 clinical trial. In this clinical trial, we evaluate the diagnosis performance of CAFFR compared with the invasive FFR in 328 patients. This invasive FFR, that means using the pressure wire to determine the FFR in the maximal hyperemia case. In those patients, we have the 14 patients have the significant pressure drift, and 2 patients have the myocardial bridge. The LAD is almost 60%. LCX is 11%. RCA is 26.5%. The bifurcation lesions is 26.5%, and the calcified lesions is 18%. We can go to the next page. And in the FLASH-1 clinical trials, the left figure shows FFR, the distribution of the FFR, the frequency of the FFR in different range. For example, FFR smaller than 0.75, FFR is larger than 0.85, or FFR is in the region in the 0.75 to 0.8, or 0.8 to 0.85. The mean FFR value equals to 0.83. And also the vessels with FFR smaller than 0.8, we have the 35%. Also, the vessel with FFR larger than 0.85, smaller than larger than 0.75, smaller than 0.85 is 36.3. That means 119 vessels. Next page. Next page, yeah. The total diagnosis, oh, no. The previous one, yeah. The diagnostic accuracy is 95.7% in the FAST. But if we discard the 14, if we discard the 14 pressure drift and 2 myocardial bridge, that the total accuracy is larger than 96%. And also the diagnostic accuracy for FFR larger than 0.75, smaller than 0.85 is larger than 90%. If we exclude the myocardial bridge, the diagnostic accuracy is 91% in the gray zone. Next page. In our own data, if we fix the aortic blood pressure, we can find if only in the when the blood pressure is the fixed pressure equals to 100, we can get the accuracy is close to 90%, but still much smaller than the then we use aortic a pressure sensor to determine the aortic blood waveform. In our case, our CAFFR is very fast because we use very special designed CFD model. Our total computational time is, our total operation time is smaller than 4 minutes. Our CFD computation is only 15 to 30 seconds. Also we have the theoretical advantage to incorporating the accurate blood pressure waveform because the measured blood aortic waveform can significantly improve the accuracy for the FFR, especially for the gray zone. We can go to the next page. The left figure shows a linear relationship between the CAFFR and the pressure where determined FFR. From the figure we can find we have a good correlations. The right figure shows a blended Boltzmann statistic. We can find it is still very reasonable. Also, we have the standard deviation is very slower. We can go to the next page. The summary for the CAFFR, that means we don't need the wear manipulation. Also, we don't need the hyperemia stimulus. It's much faster than the wear manipulation. Also, much more accurate than the CTFFR. There is one limitation. That means we have to use an empirical model to compute the hyperemia flow from the resting blood flow. In the gray zone, we can only have the 90 to 91% accuracy. The other 9% discordant comes from this part because in this gray zone, if we cannot very accurately not accurately to estimate the hyperemia blood flow, we can get some we can induce some inaccuracy. We can go to the next page. Last year, we developed a new method we call the CAIMR. That means coronary angiography-derived IMR. This part is still based on the angiograms from the two projections. We can use the teaming method to get the flow velocity. Here, I want to emphasize This flow velocity is at the diastolic period. It's not the whole cardiac vessel. So in the diastolic, using the angiogram, we can get the flow velocity as a diastolic period. And also, based on the aortic pressure waveform, we can determine the diastolic pressure wave period. And then we can put these two parts into the CFD model. And we can calculate the CAIMR. That means we can calculate the PD value as a maximal hyperemia. And then we times L. L is equal to 7.5 centimeter. That means from the inlet to the most distal position of the coronary artery. And the V diastole means the flow velocity as a diastole, and we times a parameter K. This K, we got it from the previous literature and our own clinical data. In this case, V times K, V diastole times K, we can get the flow velocity as a maximal hyperemia, as a maximal, we can get the flow velocity as a maximal hyperemia very accurately. We can go to the next page. And also we use a retrospective study for assessment of the CAIMR. Also, I want to introduce, recently we did the prospective study for the CAIMR. We got almost exactly same answer, same results like the retrospective study. In this retrospective study, we evaluate the diagnostic performance of the CAIMR compared with the invasive wire-derived IMR in 42 patients and 43 vessels. Those patients has no epicardial stenosis. That means in the angiogram, you can find it's normal. That means from the angiogram, we can find it's very normal patient, but they still have the angina pectoris. What caused it is definitely caused by the microcirculatory resistance. In those patients, the stable angina pectoris has a 57%. Unstable angina pectoris has a 21%. All of the patients no previous myocardial infarctions. Next page. In those patients, we found good correlations between the IMR and the CAIMR. Here the IMR we use the cutoff value is 25 because we know the IMR there are different cutoff value, and some doctors using the 25, some doctors using the 30, some doctors using the 35, but here we use 25 as a cutoff value. We got the area under the curve for the AUC value equals to 0.9, and also we got the very reasonable correlations between the IMR and the CAIMR. I want to emphasize those data only from the retrospective study. Recently, we did the prospective study. In almost 30 patients, we have already improved our CAIMR. We can get good correlations between the CAIMR and the IMR. We can go to the next page. This one is I can list some cases. The left figure shows CAFFR equals to 0.97. CAIMR equals to 75. And also in this patient, we use a pressure wire to measure the FFR equals to 0.95. That means this patient has no stenosis. From the angiogram, we can find it. FFR is normal, everything is normal, but the IMR equals to 80 and the CAIMR equals to 75. That means this patient has a microcirculatory has a very severe microcirculatory dysfunction. So we need to treat it by some medicine. Also in China, we have there's some drug companies, they propose different drugs, different medicines for this kind of treatment. But in the world, a lot of companies are very interested in this kind of technique. And then the next page. In this patient, the CAFFR equals to 0.91, and using the pressure wire, we got the value is equal to 1.0. That means everything is normal. And also the CAMR equals to 15, IMR equals to 20. That means this patient actually is normal. It has a normal epicardial coronary arteries, and also it has good microcirculation. The next page. In this case, from the angiogram, we can also get it found that it's very normal, but this case is a diffuse disease. For this part, we got the CAMR equals to 13 and IMR equals to 17. That means this patient has a very normal microcirculation, but this patient has a CAFFR equals to 0.6 and FFR equals to 0.56. That means this patient has this diffuse disease cause myocardial ischemia. So the patient needs some maybe the cabbage or some very long stenting. This part we have to ask the doctor. The doctor can determine it. Next page. So we have the summary for the CAMR. For the CAMR, we don't need for the wire manipulation. We don't need the hyperemia stimulus. We can get, also the operation is very fast than the wire manipulation, because in the wire, normally they inject the saline 3 times, at least 3 times, normally 5 to 8 times. They can only get the IMR value. It's very, very inconvenient. And the CAMR is, in my point of view, the CAMR is useful for the physiological assessment of the microvascular disease in patients with ischemia heart disease. But we still need more prospective studies in multi-centers to validate. Finally, thank you. Next page. Recently, we have our FLASH2 clinical trials. In these FLASH2 clinical trials, we investigate whether if the CAFFR diagnostic strategy will lead to the non-inferior clinical trial. After 1 year, compared with to a standard FFR-guided revascularization strategy, our primary outcome is a composite endpoint. Our MACE value includes all causes of the mortality, any myocardial infarction, and any unplanned revascularization. This month, maybe at the beginning of the next month, this clinical trial will start the clinical trial. Please go to the next page. Finally, thank you everyone.